the cerebrospinal fluid is actually produced by what's called the choroid plexus within the ventricles of the brain. So if you've learned about it, you already know this. If you don't, I'll explain it. There are chambers, cavities within your brain called ventricles. Now the moment you hear the word ventricle, you're thinking, but that's the heart. All that the word ventricle means is a chamber, a cavity. There are chambers in your heart called ventricles. In fact, the chamber right here in your larynx, where your vocal cords are located, is called the ventricle of the larynx, the chamber of the larynx. And there are chambers or cavities within your brain. Forming a lining in these chambers is a vascularized membrane called the choroid plexus. So the choroid plexus is the name of this vascularized membrane, this membrane with a lot of blood vessels that forms this fluid called cerebrospinal fluid. Now, something that you learn about in anatomy that's very similar is the synovial membrane. In anatomy, when you were learning about synovial joints, you learned that there are these movable joints in the body that have a vascularized membrane called the synovial membrane that forms a fluid called synovial fluid. And that fluid is located in the space between two articulating bones, like at your knee joint, and that allows movement because there's just fluid between the bones. So similarly, there's this cerebrospinal fluid formed by a vascularized membrane, not called the synovial membrane, but called the choroid plexus. Now, we wrote that the chemical composition of this cerebrospinal fluid is similar to that of tissue fluid. So you'd say, okay, so what is the one significant chemical difference between tissue fluid and blood plasma? Proteins. There are proteins in blood plasma, but they are too big to get out of the bloodstream, as we just reviewed a few minutes ago, normally to be found in tissue fluid. Well, similarly, cerebrospinal fluid is chemically like tissue fluid. It's normally lacking proteins. We covered all this back on page C2. C2 is when we really first talked about this. Now, on the next page, page 31, it shows a picture that I'll walk you through of the mid-sagittal section of the brain and spinal cord, so we can see how cerebrospinal fluid is formed and circulates. And again, I'll put a plug in. I want to remind you there's lots of resources on almost every topic on my website. I'm not going to play this video right now, but you can see that on the video they will walk you through this whole thing of how this fluid is formed and so on. All right, so you can watch that on your own time, but I'll explain it. You can sleep there. Okay, but all right. So there are I colored it in red. This is this vascularized membrane, and these are these chambers or cavities. There's a whole bunch of them. This top one right here is labeled choroid plexus of the lateral ventricle. And so this is the lateral ventricle, and this is this vascularized membrane that I colored in red. It's a membrane with a lot of blood vessels, and fluid squirts out of these blood vessels that is chemically similar to tissue fluid, meaning it's lacking plasma proteins. And this fluid starts to circulate through these different chambers and cavities and passageways of the brain. There is another vascularized membrane right below this one, right here. This is known as the choroid plexus of ventricle number 3. Now you might say, well, where does it say all that? It's got a legend right here. All right, all of this is labeled here CPV3, choroid plexus of third ventricle. Now I'm not so concerned that you memorize the names of these different choroid plexes. There's just a bunch of them. This CSF, this cerebrospinal fluid, then flows through a canal called the AS, the Aqueduct of Sylvius. It's labeled right here. I don't care that you know that. You don't have to know the Aqueduct of Sylvius. This fluid then flows into another ventricle near the bottom of the brain called ventricle number 4. And in ventricle number 4, there is another vascularized membrane that I've colored in red called the CPV4, the choroid plexus of ventricle number 4. So we can see there's a choroid plexus of the lateral ventricle, a choroid plexus of ventricle number 3, a choroid plexus of ventricle number 4. Again, I don't care that you know all those names. And then finally, right here, and this is a name that I do want you to know, there is a hole or an opening called the Foramen of Magendie. The Foramen of Magendie, also known as the median aperture. The median aperture is a hole, an opening, you know foramen means hole, where 90% of the cerebrospinal fluid comes out of the brain through this opening and enters the subarachnoid space. The subarachnoid space is this area right out here surrounding the brain and spinal cord, shaded in black. That's the subarachnoid space. So 90% of the fluid that was formed in these chambers of the brain comes out through this opening called the Foramen of Magendie. How does it have this name, Foramen of Magendie? It was named after a very famous French neurosurgeon named Magendie, and who first identified this opening. So that's it worth knowing. Now, I said about 90%, 80-90% of the fluid exits through that hole and enters the subarachnoid space. Subarachnoid space being the space between the arachnoid membrane and the pia mater. What about that other 10% of the fluid? The other 10% of the fluid, rather than coming out through the Foramen of Magendie, continues to flow through a canal that extends all the way down the spinal cord, called the central canal of the spinal cord, and it opens, that canal opens at the bottom of the spinal cord. And so that remaining 10% of the fluid comes out of the central canal at the bottom of the spinal cord into the subarachnoid space. In either case, the fluid ends up in the subarachnoid space. 90% entered it here at the bottom of the brain. The remaining 10% comes out at the bottom of the spinal cord into the subarachnoid space. I tried to summarize that at the bottom of the page. The circulation of the cerebrospinal fluid goes from the ventricles of the brain. Most of it goes through the Foramen of Magendie or median aperture into the subarachnoid space. A smaller amount goes through the central canal of the spinal cord and comes out into the subarachnoid space. Now, what happens to it then once it's in the subarachnoid space? Looking at our picture, this cerebrospinal fluid, as I indicated with the arrows, circulates up, up, up to the top of the brain. Here at the top of the brain, first of all, this S-AS, what's that? The subarachnoid space. So you can see the arrows show it's circulating up here at the top of the brain in the subarachnoid space, S-AS. Right above the subarachnoid space is a large vein. This large vein, there are really many veins. This particular large vein is labeled SSS. That does not stand for Social Security System. It stands for the superior sagittal sinus. And it's labeled right here, superior sagittal sinus. Now, in anatomy, all of you learned that some thin-walled veins in the body are called sinuses rather than veins. For example, there's a large thin-walled vein on the backside of the heart called the coronary sinus. Right? It's not called the coronary vein, it's called the coronary sinus. There are similarly many thin-walled veins in your brain called sinuses. And this particular one's called the superior sagittal sinus at the top of the brain. Now, what happens is that this fluid in the subarachnoid space is reabsorbed. It's reabsorbed back into the bloodstream by going back into this vein called the superior sagittal sinus. So here's what we're saying. Where did this fluid, the cerebrospinal fluid, come from? It squirted out of the bloodstream. And where does the cerebrospinal fluid eventually return to? It returns back to the bloodstream. It's squirted out of the bloodstream, and it eventually returns back to the bloodstream. In between, it's circulated through the brain, and it's circulated on the outside of the spinal cord and brain in the subarachnoid space. Now, we can see another picture of this if we look on page 30, actually, just first look on 32. On page 32, so I tried to summarize this on page 32, that this cerebrospinal fluid, the excess fluid goes from the subarachnoid space into these cranial venous sinuses, these big thin-walled veins in the head, cranial venous sinuses. You can see this if we look at the picture on the bottom of 33. On the bottom of page 33, bottom right, so on the bottom right, you'll notice labeled right up here is the superior sagittal sinus, this big thin-walled vein that's on the top of the brain that reabsorbs this cerebrospinal fluid. If you follow this superior sagittal sinus downwards, you'll notice that this vein kind of squiggles. And right here it's kind of shaped like a snake or like a letter S. And because of its shape, it's called the sigmoid sinus. Sigmoid means shaped like an S or a snake. So now the sigmoid sinus, just a continuation, the superior sagittal sinus kind of bends and its name changes, it becomes the sigmoid sinus. The sigmoid sinus, in some of you in anatomy, might vaguely remember having learned the groove for the sigmoid sinus vein. And then there's a hole at the bottom of the skull called the jugular foramen. And that vein goes right through that hole, and once it goes through the hole, it travels down your neck, and it's called the internal jugular vein. That's the internal jugular vein. So that's really what it's doing, is it's reabsorbing that cerebrospinal fluid, and it goes down, and then that blood is heading back to your heart through the internal jugular vein. So we've just described how the cerebrospinal fluid is formed, how it circulates, and how it's returned back to the bloodstream, how it's reabsorbed. The next obvious question is, what the hell is this stuff for? Why do we have cerebrospinal fluid? So the functions on page 32 is that the cerebrospinal fluid, which surrounds your spinal cord and brain, cushions your brain and spinal cord against trauma, injury. All right, so if you had me for anatomy, I did this amazing demonstration, and I'll do it here. This is why I get paid the big money. All right? Look. Oh, yeah. Yeah. That feels real great, real good. In other words, if we didn't have the fluid between our brain and our skull, that if a kid, and this happens especially with boys, they push each other, and one hits into a wall, their brain would slam right into the hard inner wall of their skull, bruising their brain. But in fact, there's fluid, cerebrospinal fluid, between the brain and the skull wall. And so that kind of cushions the brain. Obviously, if somebody's hitting you on the head with a crowbar, no amount of cerebrospinal fluid is going to protect the brain. But for typical kinds of falls and bumps, which certainly happens, if not to adults, and it does happen to adults, certainly happens to kids, especially boys. So that basically, most of the time when kids or adults fall to the floor, bump their head, usually there's nothing too serious in most cases. So that's the purpose of cerebrospinal fluid. It also maintains a constant intracranial pressure, a constant pressure inside the skull. As long as you've got the right amount of fluid and you don't have less than normal or more than normal, you have a constant intracranial pressure. Now, a problem, though, can develop if you have either a reduction of fluid or an increase in fluid. A buildup of cerebrospinal fluid, more than normal, is called hydrocephaly. Hydro means water, cephalic means brain.
Right.
it's commonly translated as water on the brain. You've got too much fluid. And there's many things that can cause it, including injury. And so as there's an increased amount of cerebrospinal fluid, it increases intracranial pressure. And as the intracranial pressure starts to increase inside the head, the skull, the person will lose consciousness, go into a coma, and die. So they may actually have to drill a hole in the skull, or they may have to insert a catheter, a cannula, to drain that fluid so it doesn't continue to build up. So we wrote hydrocephaly occurs when the rate of reabsorption of the cerebrospinal fluid is less than the rate of production. In other words, we know the fluid is being formed, it's being produced, and we know it's being reabsorbed. If it's not being reabsorbed as fast as it's being formed, you're going to get hydrocephaly. Again, I actually put a link here. There's a video you can watch. Let's see, I don't know if this is it. And
CSF shunt.
This shows insertion of a shunt, a catheter for cerebrospinal fluid. So,
the operation normally takes less than an hour, and it is a common procedure done by skilled neurosurgeons. Incisions are made to the head and abdomen. Tubes are then passed.
This is the catheter
under the skin.
Under the skin.
A small hole is made in the skull to allow the ventricular tube to be passed into the lateral ventricle. The peritoneal tube is then placed into the abdomen to allow the fluid to drain. After surgery,
the fluid is usually drained into, in this case, the abdominal cavity, sometimes into the esophagus, but they want the fluid that's building up to go back into your body. They don't want it dripping out of your head.
But critically, allows the physician to make small adjustments to the pressure setting by using
all right, so anyhow, you can watch that on your
eliminating
phone.
the need for further
All right, so that's known as a catheter or tube to drain that excess fluid. And obviously, if you just had a tube sticking out of your head, not only would that look really, really weird, like a water faucet where the fluid just, dripping out, but for every drop of fluid that dripped out of your head, you'd have to drink that fluid to replace it in your body. In this case, it's carried by that tube back into your body, and the fluid is reabsorbed. So you don't have to drink an equal amount of volume of water to replace that fluid that's being drained.
For how long do they have this catheter?
Well, it depends how long the problem exists. And depending upon the cause of the problem, it may be permanent, if it's a chronic problem.
Can it build up from anything else other than injury?
Yeah, it could. Sometimes it's congenital. Babies are born with this condition. That's known as hydrocephaly, and they've got these enlarged heads. Because in the case of an infant's head, remember all the bones haven't yet fused together. There are soft spots, so it just swells up. In an adult, which is actually good, because because it swells up, there's no increase in intracranial pressure. In an adult skull, there are no soft spots. It's all the bones are fused together. It cannot swell up, and all you can do is, as a buildup of fluid, you get increased intracranial pressure.
Sometimes they remove the cup, and they're really bad.
They do all kinds of stuff. So again, I'm not trying to get into the whole medicine issue of this, but for those people who didn't even know about this, now you know this is another medical issue. There are lots of medical issues. All right, returning back to where we were. All right, so we've been talking about cerebrospinal fluid and how it circulates, a lumbar puncture or spinal tap. We spoke about this last week. We said that sometimes they want to, let's say they want to diagnose spinal meningitis. The only way to definitively know whether somebody has spinal meningitis is to insert a needle between the lumbar vertebrae, usually between L3 and L4, below where the spinal cord ends, and insert the needle into the subarachnoid space, withdraw some of the cerebrospinal fluid, and see if there are bacteria in that fluid. And then you can diagnose that it's bacterial spinal meningitis, and you know which bacteria are causing the infection, and then you choose the correct antibiotic based upon the type of bacteria that's causing the infection. There are other reasons for a lumbar puncture, and this form from Brotman Medical Center in Culver City. You can see, I think we talked about this last time, they can analyze it for whether there's white blood cells in the fluid. Normally, the only time there would be white blood cells in cerebrospinal fluid is if there is an infection. There should normally never be red blood cells. If there's red blood cells in cerebrospinal fluid, it means you've got bleeding inside the brain. So if they see blood cells in cerebrospinal fluid, there's hemorrhaging or bleeding. They can measure various chemical levels. They can do a test for syphilis. They can do a bacterial culture, and so on. Now, another use of this lumbar puncture is for something called a myelogram. Just cross it out. We're not going to talk about it. Frankly, a procedure that they used to do called a myelogram has largely been replaced by modern MRIs. So they usually, when somebody has problems in their central nervous system, their brain or spinal cord, they usually do what's called an MRI, a magnetic resonance imaging. That's the most common technique for. Has anybody ever had an MRI? All right, so you know, I think we talked about that before. That's where you go into this donut tube, and you have to hear hammering in your, you know, the sound of hammering for about 45 minutes. Is that about right? You can't move, so. Anyhow, but that's usually how they do scans of the central nervous system now. On page 33, another clinical application of these lumbar punctures or spinal taps is to create a state of regional anesthesia. Now, last week we learned about aspirin and Tylenol and ibuprofen, and we said that aspirin and Tylenol are antipyretics. What's an antipyretic? It reduces fever, anti-fever. And they are analgesics. What's an analgesic? It reduces pain. The prefix A or AN means to take away, without, and algia meant pain. So we talked about this last week, it's in your notes. So an analgesic, aspirin is an analgesic, it is a pain reliever. Now I'm using the word anesthesia. Anesthesia is a different word than analgesia. A or AN means to without or to take away. Aesthesia means sensation. So this is to take away all sensation, not just pain, but all sensation. Now you're most familiar with anesthesia from the dental office. So when you've had to have a cavity filled, if you've ever had to have a root canal, so they gave you a shot, right, of an anesthetic to numb your mouth. And the purpose of the local anesthetic was to provide temporary numbing. And it wasn't that you didn't feel pain, you didn't feel any sensation. You didn't feel your tongue. Can you feel your mouth? Right? It's easy to bite your tongue, you can't even feel it. So you lose all sensation, not just pain. So that's anesthesia as opposed to analgesia. So the drugs that are used, as we're going to see in a moment here, for an epidural or spinal block are really absolutely identical to what the dentist uses in a nerve block in the face. Now, so let's talk a little bit about local anesthetics. If you ask most people, you know, who go to the dentist, you say, well, did you get a shot? And they'll say, yeah, they gave me Novocaine. Did you get Novocaine? They stopped using Novocaine 35 years ago. They haven't used Novocaine for 35 years. You didn't get Novocaine. Bet $100 you didn't get Novocaine. Bet $1,000. The most common one that's used is Lidocaine. Lidocaine's what's used. Lidocaine, like all drugs, these are called the generic names. These are the brand names. There are really many brand names for each generic name. Now, this class, we're not learning drug names. You'll have to do that when you get pharmacology in your clinical program. You'll be learning hundreds of drug names. All right? But we're just learning classes of drugs, categories of drugs. So lidocaine is a local anesthetic. Procaine is the generic name for Novocaine, which is no longer used. There are a whole bunch of these. A very common one found in many products over the counter in the drugstore is benzocaine.
What about cocaine? Don't you use cocaine?
I'm going to get to that. So benzocaine is found when people have like a cold sore in their mouth. You can get something called Anbesol or Campho-Phenique. Has anybody ever heard of these?
Yes.
And you can just apply it with a little cotton swab on the inside of the mouth, and it temporarily numbs the pain from a cold sore, which you learn in microbiology is a herpetic lesion, herpes simplex. That's a virus. But so it numbs the pain. They use benzocaine in a lot of things. It's the active ingredient in Solarcaine for sunburn pain. So if you've ever had a sunburn and you got that spray that you can spray on your back where you burned yourself, that's called Solarcaine, and the active ingredient is benzocaine. Incidentally, benzocaine is also what they do before a dentist or a dental hygienist gives you that shot of lidocaine. Just before that, they take a cotton swab and they rub benzocaine topically to just topically numb the area where they're going to put the shot. So remember what I'm talking about? So they put a little topical benzocaine before they give the injection of lidocaine. And now, of course, by looking at these names, we're thinking, hey, local anesthetics, lidocaine and procaine and benzocaine, and we're thinking, what about cocaine? Well, cocaine also has local anesthetic properties. In fact, before they developed these modern synthetic local anesthetics, they did use cocaine as a local anesthetic. However, cocaine has other actions as well. It's a powerful stimulant of the brain. And so most people, who are taking cocaine, and most people taking it, it's usually illegal, but it is a legal drug, but they're usually using it for illegal reasons. Well, here's what they do. They commonly will snort it up their nose. That's one way to take it. They take a straw. I'm trying to give you helpful, handy hints. So it's a white powder. People will snort it with a straw up their nose, and it wires them. They feel like Superman for a number of hours. Interestingly, though, it numbs their nose. It causes local anesthesia wherever they're introducing it into their body. So it is a local anesthetic, but it also affects the brain. All right. Now, how do local anesthetics work?
Professor?
Yep.
Why do you have to snort it? Why can't you take it?
Well, you can just swallow it. It's, this is just another way. It's a faster onset because it goes right into the bloodstream in the vessels of the nose rather than swallowing, and then it's got to be absorbed across the stomach. So in the intestines, so you get a faster onset of action. Usually when you swallow anything, it takes about 25 minutes before you start to get any effect. So if somebody wants to rush, they can snort it. All right, how do these local anesthetics work? They temporarily block the conduction of action potentials in excitable cells. So they block the sending of these electrical currents called APs, action potentials, in excitable cells. Now, what are excitable cells? There are two categories of excitable cells in our body that conduct action potentials. Nerve cells conduct action potentials, and muscle cells all conduct action potentials. So both nerve cells and muscle cells are excitable cells. And that includes heart muscle cells. Heart muscle cells are also muscle cells. So all nerve cells and all muscle cells are affected by local anesthetics. So, in fact, when you mention lidocaine to somebody who works in dentistry or dental hygiene, they will say, oh, lidocaine, that's a local anesthetic we use to block the conduction of action potentials in peripheral nerves in the face to reduce sensation for dental procedures. But if I say the word lidocaine to most nurses or physicians, you know what they think of? They think of it as a cardiac antiarrhythmic. Lidocaine is the most important drug used in a hospital to treat electrical arrhythmias of the heart. abnormal electrical currents in the heart. And so they call lidocaine a cardiac antiarrhythmic. One of the most common arrhythmias, electrical abnormalities of the heart, especially following a heart attack, are called PVCs, premature ventricular contractions, which is due to abnormal electrical activity in the heart following a heart attack. And they treat it with lidocaine. What does lidocaine do? It slows down the conduction of these abnormal action potentials, these abnormal electrical currents.
How is it administered in the second example?
In the second, it's given IV drip.
Okay.
Yeah. So is how it's given. Now, I want to broaden this concept because the concept I want you to know is more beyond just remembering that lidocaine is used for nerve block in dentistry and in medicine, and also as a cardiac antiarrhythmic. Any drug that affects the electrical activity of the nervous system similarly will affect the electrical activity of muscles, including heart muscle. That's the concept I want you to know. If it affects electrical activity, it affects the electrical activity of all excitable cells, nerve cells and muscle cells, including heart muscle. Let me give you another example besides lidocaine. Has anybody ever heard of the drug Dilantin? Phenytoin or Dilantin. Anybody ever heard of it? What's Dilantin used for?
People have seizures.
Exactly right. Dilantin is a commonly used anti-seizure medication to treat and control epileptic seizures. An epileptic seizure is abnormal electrical activity in the brain. But Dilantin is also used as a cardiac antiarrhythmic. It's also used to control abnormal electrical currents in the heart. I even go one step further. When people have very severe arrhythmias of the heart, they will defibrillate their heart, right? They pass a strong electrical current into the chest, into the heart, to try to control these abnormal electrical currents. You've heard that's called defibrillation or cardioversion. Have you ever heard of it? Every episode of ER used to have this. Every single episode they had to defibrillate. All right, now, when people have very severe types of seizures or depression, they will do ECS, electroconvulsive shock therapy, and pass a strong electrical current into the head. So basically the same kinds of medications and treatments they use for electrical problems in the brain, similarly they treat with electrical problems in the heart. That's the broader concept I want you to understand. All right, so lidocaine is used in dentistry, and lidocaine is what they inject for an epidural block. Let's go down to right here, this picture. This shows a guy who's got a needle between his lumbar vertebrae, and they're withdrawing some cerebrospinal fluid. The needle is inserted in the subarachnoid space, and cerebrospinal fluid can be drawn. Right above the picture of him, it shows, here's the needle, and the black line here represents the dura mater, that thick dura mater membrane, and this is the spinal nerve. Spinal cord ended right here, but these are the spinal nerves, and they are surrounded by cerebrospinal fluid in the subarachnoid space. Now, in terms of administering a local anesthetic, there are two ways to administer the local anesthetic. You can either insert the needle also into the cerebrospinal fluid in the subarachnoid space and inject the local anesthetic right here, which is exactly the same as what we saw right on this side. All right? Or they can have the needle just outside the dura mater. What do we call that space just outside the dura mater? The epidural space, and that's known as an epidural. Now, when they insert and release the local anesthetic into the cerebrospinal fluid in the subarachnoid space, that's called a spinal block or a saddle block. If the drug, the local anesthetic, is released just outside the dura mater, it's called an epidural block. Which method do you think probably provides greater anesthesia? The spinal, because the spinal gives the drug
Directed to the
right
nerves.
into the fluid surrounding these nerves, and it basically stops conduction of action potentials in these nerve fibers, in the nerves. Incidentally, we said that local anesthetics block the conduction of action potentials, right, in nerve cells and muscle cells. That means that it blocks the conduction in both sensory neurons and motor neurons, both, in both. So when this local anesthetic is around these nerves, what's inside those nerves? So sensory neurons and motor neurons. Didn't we review that? 2 types of sensory neurons, 2 types of motor neurons are inside those nerves. So it blocks conduction of both sensory information coming in, and it blocks the action potentials of nerve impulses going out to the effectors. So there is both loss of sensation and paralysis. So when a woman is given either a spinal block or an epidural, she loses sensation and has paralysis from the level of the lower chest all the way down to her toes. So for as long as that drug is exerting its effect, there is both loss of sensation and paralysis. Under the influence of either a spinal block or an epidural, you can't just stand up and start walking. There's paralysis. Now, what they do typically with these blocks, and the most common method they use is the epidural, even though it's not as effective,
It's more safe.
it's safer, because that way they don't risk hitting a nerve when the needle goes through the dura mater. Okay, that's considered safer, but less effective. All right? But the way they typically do it, they put the needle in, and then they connect a drip line. And they can control the rate at which this local anesthetic is going and being dripping out around the dura mater, around the spinal cord. Furthermore, they can also, typically when a woman is getting closer to the time when she's going to start pushing, they stop giving the drug. So the effect starts to be reduced. They can also control how big of effect it is based on the position that the woman is in. If she's lying down horizontal, the drug starts to circulate upwards, right? It's flowing towards her head, right? Cerebrospinal fluid circulates to the top of the brain, and then it's reabsorbed back into the bloodstream. But sometimes they may have the woman sit up slightly. If she sits up, gravity tends to keep that drug lower down around this lower part of the spinal cord and stops it from circulating as quickly up towards the head. So that based on the drip rate and the position that you're in, it can be used to control the extent of anesthesia and paralysis. Now, the original use of epidurals was in C-sections. But today, I think it's up to 80–90% of women who deliver not through an abdominal incision in the abdomen, in the uterus, called a cesarean delivery, but just a normal vaginal birth, out the birth canal or vaginal canal. About 80–90% opt for an epidural. Why do so many do it? You know, even though it's got that scary needle, it's called pain of labor. And usually, most women, if it's their first child, they usually say, I'm not going to use the needle, and then within 2 hours of bad, intense labor, they change their mind.
Exactly.
Okay, it usually doesn't take very much difficult labor before most women say, you know, I'm going to go with that needle. Okay, that's what the majority of women do today. Now, the beauty of a spinal or epidural block is that it doesn't affect the baby. The drug is around the spinal cord of the mother. It is not in her bloodstream. Normally, any drug that's in the bloodstream of the mother will cross the placenta and enter the baby's bloodstream. So this method is the only method where there's a drug, but it's around her spinal cord, not in her bloodstream. Now, what are the other possibilities that they used to do? So let's say they used to do general anesthesia, right, where they knock you out. Has anybody ever had surgery when you went under general anesthesia? Right? So they always tell you, you know, they start to give you the gas. They say just start to count. Right? They'll say count from 1 to 10, count from 10. You figure, if it's your first time, you figure I'm probably going to be counting for a while. How long do you count?
3 seconds.
Yeah, you get to the third number and you're out. Now, when you inhale the drug into your lungs, right, it goes into the bloodstream through the pulmonary circulation. It goes from the lungs into the bloodstream, and once it's in the bloodstream, it's carried everywhere in your body, including up to your brain. So, and if it's in the bloodstream of the mother, it would cross the placenta, and that general anesthetic would create general anesthesia of the baby, which is not such a good thing. For another approach is to just get a shot of a narcotic, pain reliever, like Demerol, right? Just get a shot of Demerol. But if they're giving this pain reliever, this narcotic, into the mother's bloodstream, anything that's in her bloodstream will cross the placenta, and that narcotic will be affecting the baby. This is the only method that doesn't affect the baby. It also has one other advantage. This unlike general anesthesia, the mother is awake. She doesn't feel the lower part of her body. She can't move the lower part of her body, but she's totally awake. So when the baby is born, either by C-section or vaginal, they hand her the baby, she holds the baby. In the old days of general anesthesia, she was totally out, woke up a few hours later, and they handed her a baby, and she didn't know if it was her baby. Have they ever made a mistake?
Yeah.
Yes, they have. Yes, they have made mistakes. Gave the wrong baby to the wrong parents. That's happened a number of times. Incidentally, that's why if you've been to the hospital lately, either yourself or any relative or friend, you notice how constantly they keep checking the name band. Because they used to just go into a room and they say, here's your medication, and they ended up giving it to the wrong patient. So now they're really, really careful. They won't do anything before they double check that they got the right patient. You notice that? They check that over and over again. Yeah.
So the spinal saddle block, you said is more dangerous because they can hit a nerve?
Yeah, in other words,
When would they want to do that over the epidural?
well, normally they'll choose the epidural over the spinal.
Okay,
The only time they have no choice is if they want to withdraw cerebrospinal fluid.
okay,
Then they have no choice.
okay,
So for spinal meningitis, they've got to draw some cerebrospinal fluid. They have to do a spinal
okay.
tap.